All right, hi guys, my name is Ankita, one of the PGY4s. I'll be talking about red eye today, and first I'll talk about the anatomy of the eye, and then my presentation is actually a question-answer format. So let's get into it. Anatomy of the eye. So this pointer. So the eye can be divided into three layers. The first layer, the outermost layer, is the sclera in the conjunctiva. That forms a fibrous layer. If that is compromised, that can cause infection. And then the middle layer is the vascular layer that it comprises of the choroid. I don't know how. Let's see if I can get the pointer perfect. So the middle layer is a vascular layer that comprises of the choroid, the ciliary body, and the iris. And then the innermost layer is the retina. The lens is right here. That separates the anterior structures of the eye from the posterior structures. And limbus is the junction where the conjunctiva and the sclera meet. So that would be important because we'll be talking about a pathology there. So let's start with and this is the other aspect that I wanted to show you. The color of the eye is given by the iris. This is the pupil right there. The cornea goes from here to here, and the sclera is right. And then the limbus is like right here. You'll see the limbus right outside the iris. So first question. A 22-year-old male complains of pain, photophobia, and vision loss in his left eye. He has a history of sickle cell anemia. His vision is 20 out of 200 in the left eye with a IOP of 30 mm mercury. You see the above finding in his eye. Which of the medications should be immediately administered to the patient? Your choices are IV ketorolac, IV mannitol, topical acetazolamide, and then topical timolol. So before you guys answer, what is this? Like, what is this called? Perfect, excellent. All right, so which medication should be administered? I think I heard the answer. What was that? D, perfect, yeah, timolol. And the reason for that is when somebody has hyphema, there's a risk and increase in IOP. So you want to give them timolol, otherwise their optic nerves get damaged and they risk losing the vision. So this is hyphema right here. Hyphema can be caused by trauma. It could be blunt trauma, penetrating trauma, and then non-traumatic causes, which includes underlying pathologies like diabetes with causing neoproliferative disorder, like the shoddy blood vessels. It can be caused by sickle cell anemia. So if somebody is presenting with traumatic causes, you want to rule out open lobe rupture. That's very important before you start to check the pressures and stuff like that. And then you want to call ophthalmologist right away. Then the other thing with hyphema is increase in IOP, which is something you want to make sure that their pressure doesn't increases. So you want to elevate the head of the bed. If they're nauseous, if they're throwing up, give them Zofran and just call ophthalmologist. They'll take care of that. Do a good exam. Make sure there's no inferior wall fracture causing entrapment of the eye, anything like that. All right, so that's for hyphema. And then clinically, you can see this is hyphema. Patients will be complaining of photophobia, decreased visual acuity, and then anisocoria, which is basically unequal pupil size. All right, so one thing more for hyphema is graded according to scale of 1 through 4, depending on how bad it is. Grade 1 is when the blood in the interior chamber is less than 33%, 2 is between 33 and 50, and then grade 3 is over 50, and then 4 is complete opacification, secondary to the blood. And the grade 4 is also called 8-ball hyphema. Moving on to the next question. So a 55-year-old woman presented with acute onset of redness in her left eye, which she noted upon awakening in the morning. She had no pain, no ocular discharge, no photophobia, no blurry vision, no history of blunt trauma. The patient. What was that?
Microphone's rubbing your shoulder.
Oh, so sorry. Okay, and then on exam, she was normotensive. Her pupils were equal and reactive, and her corrected vision is 20 out of 20, so no vision changes. Which of the following is the most likely diagnosis? Acute angle closure glaucoma, keratitis, subconjunctival hemorrhage, viral conjunctivitis, or hyphema? Any answers? C, perfect, yeah, that is subconjunctival hemorrhage. So let's talk about it. So subconjunctival hemorrhage, so this can be because of really benign causes like Valsalva, somebody sneezed really hard. It could be caused by systemic disorders like somebody who has supratherapeutic INR, recently started on warfarin, and then somebody who just vomited. We see a lot of this in our drunk patients who fell, or it can be caused by trauma too. If it is caused by trauma, do a proper eye exam, rule out open globe rupture, and you don't need to call ophthalmologist for this if it's because of non-traumatic causes. And patients can go home if there's no trauma involved. It'll get better in like 3 to 4 weeks. Spontaneously, the body's going to reabsorb the blood. And you can see the limbus in this one right here very clearly. So you'll see the blood is not in the anterior chamber, unlike hyphema. Even in this one, you can see a clear demarcation. So it's not filling the anterior chamber. So that's how you can tell apart conjunctival hemorrhage from hyphema. And patients will have, it's like basically painless red eye that they're presenting with. I actually had a patient yesterday. I'm not sure how much time I have, but I'll keep on going till Maninder tells me to stop talking.
Use the mic. Oh, thank you. No, the little guy near your left shoulder. Yeah. It's hard to
Oh my goodness, I'm so sorry. Halfway through my presentation I hear that. Okay, all right. So the next question is, a middle-aged woman presents to the ED complaining of decreased vision and an aching pain in her right eye. She says it came on after an argument with her husband, of course, right? Earlier in the evening, the eye pain had progressed to a frontal headache. She could hardly read anything on a Snellen's chart, and while you were assessing her visual acuity, she started to vomit. This is what her right eye looks like. What do you guys think? I have no answer choices because it would be pretty obvious, but just looking at the physical exam, what do you think could be? Perfect. Oh my God, that's awesome. All right. Okay, this is acute angle closure glaucoma. Just wanted to point out a few things here. So you see the ciliary flush, the red thing right here, that's ciliary flush. See the dilated pupil, and the cornea is hazy, it's cloudy. So that's how you can tell. This is a better picture to show the difference between the two eyes. So the pupil, classically, it is called mid-dilated fixed pupil. So you'll notice anisocoria on the exam, where anisocoria is basically unequal pupils. And then this would be dilated, it'd be fixed. You'll see ciliary flush. Patients who have this, they do have family history of glaucoma. Usually older patients get it, and they're really in a lot of distress. Usually it's unilateral, but I've seen bilateral also presenting. They'll be complaining of headache, really bad headache. They might not tell you about eye complaints, so it's important to also check their eyes and not think that there's a stroke code because of a really bad headache. We had somebody who we thought was a stroke code, got a CT head, and it ended up being acute angle closure glaucoma actually. So that's how they'll be presenting: photophobia, tearing of the eye, and you want to call the ophthalmologist right away for this thing because they risk losing the vision. The optic nerve, it can get damaged. And the pathophys for acute angle closure glaucoma, we probably all know, but I'm just going to say that again, is basically the anterior chamber, the angle of the anterior chamber, so that closes or it becomes narrow, where the aqueous humor can't flow out and it just builds up behind, causing increase in the IOP. So there are few medications that are given. There's beta blockers are given, timolol is given, alpha agonist, alpha-GAN, and then xylantin is given. It's one of the prostaglandin. But do call the ophthalmologist right away because everybody has a little different combination of drugs they like to use. And but we can definitely give them timolol, put them in a dark room, the IOP is usual. The normal IOP is between 8 and 22. In these patients, it's usually 45, but anything over 22 is elevated IOP, and you measure that with a tonometry. All right, so the last question is an 18-year-old male presents with red eye. He has been sick with upper respiratory symptoms for 2 days. Exam is notable for bilateral conjunctival injection with scant discharge. He has rhinorrhea and sounds congested. He has a palpable preauricular lymph node on left. Which of the following is the most likely cause of his red eye? Firstly, what kind of conjunctivitis is this? Is it perfect? Yeah, and then what virus are we talking about? Because we already ruled out staph and strep.
Adenovirus?
Perfect, yeah, so it is adenovirus. So let's talk about conjunctivitis now. So conjunctivitis can be either infectious or it could be non-infectious. I probably should have added a disclaimer for this slide. So there's infectious versus non-infectious. Infectious is a bacterial or viral, and then non-infectious is the bottom picture. So this is allergic conjunctivitis. Bacterial, there's mucopurulent discharge, like you can see. It can be unilateral, but 50% of the times it's bilateral. And then in viral conjunctivitis, 20% of the time it'll be bilateral, this tearing of the eye, just watery discharge, and they will be endorsing having rhinorrhea and other sort of viral syndrome. And then allergic conjunctivitis, that is bilateral. They would endorse like seasonal allergies and things like that. It's important to get a good history for conjunctivitis because your treatment is going to be geared accordingly. If somebody is coming with viral and you give them erythromycin, it won't help. If somebody is coming with allergic conjunctivitis and you give them erythromycin, it would not help. So it really only helps for bacterial conjunctivitis. On the next slide, I do have a table differentiating these three. And then pruritus is something else that you'll see in allergic. Bacterial and viral won't really have pruritus. And then in the last slide, I have treatment. So for bacterial, you do erythromycin, TMP, polymyxin B. If people are wearing contact lenses, they should not be wearing it, otherwise they can get corneal ulcers and things like that. You want to cover for pseudomonas, so ofloxacin and ciproflox. For viral and allergic, it's mostly supportive. So NAFCON A is given for viral and allergic. NAFCON A is a combination of your antihistamines and vasoconstrictors. And then cromolyn sodium is a mast cell stabilizer that can be given for allergic. So that's the end of my presentation. Thank you.